Hi, my name is Rudy Nunez. I am a PharmD candidate class of 2024, and this is my drug information presentation on azithromycin. It has various different brand names, and here I listed two, Zithromax and Azicite. Azithromycin is a macrolide antibiotic. Its usual dosage forms include oral tablets, intravenous solution for reconstitution, and ophthalmic solutions. Its typical uses include infections in the chest, such as pneumonia, and then ear, nose, and throat infections as well. And this also includes sinus infections. And here on this slide, we have images of the three different formulations. We have the tablets up at the top, and then in the bottom left, we have the ophthalmic solutions. And to the right of that, we have the vial that's going to be used for reconstitution for intravenous route. On this slide, we're going to discuss the pharmacokinetic processes of azithromycin in terms of the ADME processes. In terms of absorption, we have rapid absorption from the GI tract. Bioavailability, this medication is 34 to 52% bioavailable once given by oral route. And for the oral suspension, it has an increased bioavailability if given with food. In terms of distribution, we have extensive distribution into the tissues. It distributes well into skin, lungs, sputum, tonsils, and cervix. And as you'll see, this is some of the sites of action for our medication. It has poor penetration into the cerebral spinal fluid and has a volume of distribution between 31 to 33 liters per kilogram. Metabolism, it's hepatically metabolized to inactive metabolites, and its time to peak in serum is going to be between 2 to 3 hours. In terms of excretion, we have biliary excretion, 50% unchanged, and this is the major route. And it is 6 to 14% excreted by urine, unchanged as well. The half-life of elimination in infants and children 4 months to 15 years is 54.4 hours, and in adults is between 68 to 72 hours. So it is theorized that with the long half-life, it could lead to more and more antibiotic resistance over time, and so this is one of the major concerns in terms of pharmacokinetic concerns. And since it is a newer macrolide, azithromycin is more stable in acidic conditions when compared to erythromycin, its predecessor, and it provides better oral absorption, better tolerance, and pharmacokinetic properties. The mechanism of action of azithromycin is not definitively known, but may be related to the suppression of the inflammatory response, suppression of biofilm production by bacteria, and or the direct antibacterial effects that it can produce. Azithromycin inhibits bacterial protein synthesis by targeting the 50S subunit of bacterial ribosomes. And here in the image, we see azithromycin illustrated in red, and it is targeting the 50S subunit of this ribosome. Thus, it is stopping protein synthesis and is known as a bacteriostatic antibiotic. It does inhibit and is correlated to concentration. So the higher the concentration, the greater the inhibition of protein synthesis. On this slide, I wanted to list some of the indications and usages for azithromycin. And this is not an all-inclusive list, but it is a pretty comprehensive list. It can be used for acute bacterial exacerbations of chronic bronchitis in adults, acute bacterial sinusitis in adults, uncomplicated skin and skin structure infections in adults, urethritis and cervicitis in adults, genital ulcer disease in men, acute otitis media in pediatric patients, and pediatric patients 6 months of age and older, community-acquired pneumonia in adults and in pediatric patients, and again, 6 months and older for pediatric patients, pharyngitis and tonsillitis in adults and pediatric patients, and for this pediatric patient population, it would be for 2 years and older. And it can also be used for Mycobacterium avium complex infections, which is an atypical infection that can happen, and patients with HIV are more at risk at this. So on this slide and on the next slide, we're going to talk about dosage and administration of azithromycin. This slide talks about common adult dosing for community-acquired pneumonia, for pharyngitis and tonsillitis, and for skin structure infection, when it's not complicated, we start off with 500 milligrams, one dose daily for 1 day, and then 250 milligrams, one dose daily for days 2 through 5. And it's going to be a total of 5-day therapy. For acute bacterial exacerbations of COPD, chronic obstructive pulmonary disease, we have 500 milligrams once daily for 3 days, or the same dosing as above. Again, 500 milligrams day 1, then 250 days 2 through 5. For acute bacterial sinusitis, we have 500 milligrams once daily for 3 days. For genital ulcer disease or non-gonococcal urethritis and cervicitis, we have one single 1 gram dose. And then when we have gonococcal urethritis and cervicitis or gonorrhea, we have one single 2 gram dose given. In this slide, we list common dosing and administration of pediatric patients. For acute otitis media, we start off with 30 milligrams per kilogram as a single dose, or 10 milligrams per kilogram once daily for 3 days, or 10 milligrams per kilogram as a single dose on day 1, followed by 5 milligrams per kilogram on days 2 through 5. For acute bacterial sinusitis, we can start off with 10 milligrams per kilogram once daily for 3 days. And for community-acquired pneumonia, we do 10 milligrams per kilogram as a single dose on day 1, followed by 5 milligrams per kilogram once daily for days 2 through 5. For pharyngitis and tonsillitis, we give 12 milligrams per kilogram once daily for 5 days. In this presentation, I have mainly been discussing the systemic administration of azithromycin, but on this slide, I wanted to just highlight some of the details of the ophthalmic solution and what it is used for. It is indicated to treat bacterial conjunctivitis, and it's good to distinguish between bacterial conjunctivitis and viral conjunctivitis or allergic conjunctivitis, because if it's viral or allergic, then azithromycin is probably not going to help very much. And it can probably hurt the patient more. So here we have a healthy eye in the top left. In the top right, we have bacterial conjunctivitis. And this is a red eye, but it also has the rheum collecting around the eye boogers. And then in the bottom left, we have viral conjunctivitis. And in the bottom right, we have allergic conjunctivitis. And both of these are red eyes, but allergic conjunctivitis has more tear production. For the adult dosing, we instill 1 drop into the affected eye. It could be 1 or 2 of the eyes, twice daily for 2 days, then 1 drop into the affected eye, once daily for the next 5 days. In children and adolescents, we are going to instill 1 drop into the affected eye twice daily for 2 days, and then 1 drop once daily for 5 days. And we're going to make sure to counsel our patient to tell their doctor if there's any vision changes, eye pain or severe eye irritation, or eye discharge. So now that we've discussed the indication and dosing and administration of azithromycin, we're going to discuss some of the adverse reactions that can happen while a patient is on azithromycin. In greater than 10% of our patients, we're going to see diarrhea, nausea, vomiting, and abdominal pain. In 1 to 10% of our patients, we could see headaches, elevated liver enzymes, and flatulence. And in a rare, about 1% of our patients, we're going to see Stevens-Johnson syndromes or severe hypersensitivities. Patients going to be counseled to be aware of Stevens-Johnson syndrome, which is a blistering skin reaction that can happen. We also could see myasthenia gravis, which is a autoimmune disorder that affects the nerves between skeletal muscles. So that can result in weakening of the skeletal muscles. You could also see chest pain, QTC prolongation, or torsades de pointe. Again, so we're going to use it with extreme caution in patients who have heart conditions or who are currently taking medications that have QTC prolongation effects. And we could also see hepatitis. So again, using severe caution with a patient who already had hepatitis. So listed here are some of the common drug-drug interactions. And in this table, we have the typical agents, the mechanism, and the clinical management of these patients. The typical agents include agents that prolong QTC interval. This could include class C antiarrhythmatics such as amiodarone, sotalol, dofetilide, or ibutylide. Again, azithromycin does have QTC prolongation risk, and so in combination we have an additive toxicity to the heart, so additive cardiotoxicity, and we're going to avoid this combination. In patients using statin, we have an increased risk for rhabdomyolysis, and we're going to use with caution in patients if we have to use azithromycin. In patients who are taking digoxin, we have an increased risk for digoxin toxicity, and we're going to also use with caution as well. In patients currently taking warfarin, we're going to have an increased bleeding risk, increasing the INR. So we're going to have, because of the inhibition of warfarin metabolism, so we're going to have to monitor INR more closely. In patients who are getting the typhoid vaccine or the cholera vaccine, we have listed here that antibiotics may decrease therapeutic effect of vaccines, so we're going to avoid concurrent use of this. So we're going to wait until after we stopped using the antibiotic. So in this slide, we're going to go deeper into some of the warnings and precautions and what we do in response to these events. So if a patient experiences a history of or has a history of cholestatic jaundice or hepatic dysfunction associated with azithromycin use, we're going to have azithromycin be contraindicated moving forward. If the patient experiences an allergic skin reaction, this could sometimes be fatal, so we're going to discontinue azithromycin. If the patient experiences hepatotoxicity, again, this could be severe and sometimes fatal, we're going to discontinue azithromycin. If the patient is a neonate and they're given azithromycin within 42 days of life, and they experience infantile hypertrophic pyloric stenosis, we're going to direct the patient and caregiver to contact their physician if vomiting occurs or if irritability while feeding occurs. If the patient experiences QT prolongation or cases of torsades de pointes, the risk for using azithromycin is going to be highly considered, and azithromycin does have a cardiovascular risk associated with it. If the patient experiences cardiovascular death, we're going to evaluate the risk and what happened with that patient. And if the patient experiences clostriditis difficile associated diarrhea, this is otherwise known as C. diff, we're going to evaluate the patient if diarrhea occurs. So if diarrhea occurs after using azithromycin, we're going to evaluate the patient to see if it was caused by azithromycin or not. Some of the monitoring parameters for a patient while using azithromycin include to monitor liver function tests and symptoms for hepatitis. Hepatitis symptoms could include malaise, nausea, vomiting, abdominal pain, or fever. We also have to monitor CBC, the complete blood cell count, with differential, audiogram with prolonged use, so this is to test for the hearing loss, and ECG for QTc prolongation. Toxicity monitoring is going to seek medical attention if chest pain occurs, if blistering rash occurs, or if extreme fatigue occurs. Efficacy monitoring, of course, includes resolutions of signs and symptoms of infection. So as we're doing research for which antibiotic is best suited and where our clinical practice is going to be directed towards, we have to refer back to clinical practice guidelines. And my go-to is always the Infectious Disease Society of America, and this is a screenshot of their collaboration with the American Thoracic Society documents. This is a clinical practice guideline for the diagnosis and treatment of adults with community-acquired pneumonia. And in terms of azithromycin, I wanted to highlight community-acquired pneumonia because in 2007 guideline update, it was strongly recommended to use azithromycin as monotherapy. And for those who have worked in retail, they would remember that we have azithromycin monotherapy given as a box of 6 tablets. You give 2 on day 1 and 1 tablet on day 2 through 5. And it was a very common therapy that was given to a lot of patients with community-acquired pneumonia. And in the next slide, we'll see that in 2019, that strong recommendation is no longer the case. So this is going to be table 2 from that same clinical practice guideline as referenced in the previous slide. We have here a comparison between 2019 and 2007's clinical practice guideline. In the last row, we have macrolide monotherapy. And in 2007, it had a strong recommendation for outpatients with community-acquired pneumonia. And in 2019, now we have a conditional recommendation for outpatients based on resistance levels. In the next slide, you'll see an example of where we have our breakpoint of that resistance level. So this is table 3 of that same clinical practice guideline, and this is going to be highlighting the initial treatment strategies for outpatients with CAP. So patient who doesn't have other comorbidities or risk factors for a more severe infection, such as MRSA, MRSA, or Pseudomonas aeruginosa, we could start with the standard monotherapy of amoxicillin, doxycycline, or macrolide if pneumococcal resistance is less than 25%. So here I wanted to just highlight the local pneumococcal resistance is less than 25% is our breakpoint at which local resistance or susceptibility where it should be. And then a patient with comorbidities, we could do combination therapy with amoxicillin, clavulanate, augmentin, or cephalosporin, and macrolide or doxycycline. So here I just wanted to highlight that we're still using macrolide. It is still clinically relevant and is still a good antibiotic. Azithromycin can still be used, but it is now losing its favor as monotherapy. But in combination, it does have a good role in clinical practice. And azithromycin resistance can be associated to many different mechanisms. And one of the mechanisms is an inability of the organism or the bacteria to take up the antibiotic. For some reason, this bacteria has made some type of phenotypic change in which the antibiotic is no longer able to penetrate its cell wall. We also have efflux pumps, or sometimes we do have the antibiotic is able to penetrate the cell wall, but it's being pumped back out by efflux pumps. Or we have a decrease in affinity of 50S ribosomal subunit, which is our mechanism of action for azithromycin. And this website is highlighted in the onlinelibrary.wiley website. Okay, so with resistance patterns in mind, I wanted to, in this slide, show some of the ways in which we could keep track of susceptibilities and resistance in our clinical practice. So I pulled these two tables from different resources, but the resources are listed here. And I thought it was appropriate because we were talking about macrolides and how macrolides in clinical practice are now told to be used monotherapy for outpatients if they have a resistance pattern of less than 25%. And on the table on the left, we'll see that azithromycin is listed as 61% susceptible, denoting the idea that streptococcal pneumoniae is 61% susceptible to azithromycin, and thus 39% resistant. And so if this was your cultures and sensitivity report for your patient and it has a 61, it's less likely to be used. So we wouldn't recommend azithromycin to be used monotherapy for this patient. But then if we compare it to amoxicillin, which is 97% susceptibility to streptococcal pneumoniae, it means that our streptococcal pneumoniae infection will likely be 97% susceptible, so likely to stop the infection. And this is kind of how we're going to use these types of susceptibility patterns. The table on the right is a sample antibiogram, and the first column is the antibiotics. The next set of columns in pink are the gram negative. The column in blue is going to be the gram positives, and in white we have the summary report from that sample antibiogram. And these are not real numbers. It just kind of was like a visual from a bird's eye view of what a sample antibiogram would look like. And it's not going to be specific for the whole world. It's not going to be specific for the United States. It has to be institution specific. And so in that case, we're going to relate it back to our policies and procedures that are going to be institution based. So if your antibiotic stewardship committee or program says that azithromycin is not susceptible, we wouldn't use it. But if we do say that azithromycin is at that susceptibility level, like 75% or greater, then we could possibly use it as a monotherapy for our patients in terms of monotherapy. But again, like in the previous slide, I did show that it was used in combination many times, and it can be used for other types of indications as listed in the beginning of this presentation. So it's not to discourage the use of azithromycin, it's just to provide kind of where our therapy is going nowadays. So we're pushing away from using azithromycin for all community-acquired patients, as it was originally strongly indicated in 2007, and now in 2019 we're pushing away from that, and these are some of the reasons. Here are some of the clinical pearls that are going to be your take-home points from this presentation. So again, some key counseling points include finishing the full course therapy. We're always going to recommend our patients to finish all their antibiotics as prescribed when given antibiotics. We're going to avoid antacids that contain aluminum or magnesium while taking azithromycin. We're also going to use in caution in patients with severe hepatic, renal, or cardiac issues. Our max dose in children is going to be 500 milligrams. And antimicrobial resistance is a concern with macrolide therapy, so we're going to refer to institution-specific policies for antibiotic selection. So disregard the idea that if one institute is using a lot of azithromycin, we can too. This is going to be based on resistance and susceptibility patterns at your location specifically. So this is going to be institute-specific policies that are going to highlight which antibiotic is best selected for your practice. And here are some of the references used in this presentation. I want to just encourage anyone who is interested to look through these references and to do their own research. Clinical practice is always changing, and so we have to keep track of the changes and updates that are happening.